good morning or good afternoon to everybody who joins today the ISN-KDIGO webinar series on complement in glomerulonephritis. I'm really pleased to welcome you today. And today our theme is the role of complement beyond glomerulonephritis. And we will focus actually on the transplantation and other kidney disease, also like diabetic nephropathy. Yeah, I'm really happy that we have here today really great speakers, which are like in clinic and as also in the experimental setting of these disease, really established. So first we will have a talk of Leonardo Riella from the US. He actually holds the Harold and Ellen Dancer Endowed Chair in Transplantation and is Associate Professor of Medicine and Surgery at the Massachusetts General Hospital, Harvard Medical School in Boston, USA. He's also the director of the Kidney Transplantation Program and a senior investigator in the Center for Transplantational Science. So I think we will get a really great talk today. And the research focus of Dr. Riella is the understanding of mechanism in immune regulation, investigating glomerular disease, recurrence after transplantation, and also, and especially interesting for us, developing new therapies and new options to mediate immune tolerance. So I think, yeah, I'm really happy and glad that we have you here today. And I think we start directly. But before we get the talk, I have two questions actually to you, because we wanted to know actually who joins these webinars and these sessions. So Paul 1 would be good now. So you will see now, I don't know if I can see them, but I think you will see now 3 questions, and there are 2 questions, and you get the so the first question is, how often do you join the ISN webinar? Because we would like to know if you join the first time, if you do it on a regular basis, or only because you are interested in complement. So if you could answer now, it would be interesting, so we know more about our audience today. And you have around 30 seconds, and then we will see the result, and then we may focus more like in the discussion on the audience. So we see, okay, obviously we have like a 50% who join on a regular basis on these seminars, so that's really good, and I think a good way to get the newest information about research and clinical practice. Some of them are like around 40% because this topic is really interesting. I think it gets more and more interesting since we have a lot of clinical trials in complement inhibition, and only a few are the first time here. So, and then I think we follow with the second question, because this is which kind of specialization, also with which professional direction you have. So are you a nephrologist, a transplant surgeon, a specialist in internal medicine, an immunologist, or do you do something else? So I think that's interesting also for our discussion. And after this, I think we start, so we have enough time for the talks, and then at the end, we have 2 talks today, and at the end, we have around 15 minutes to discuss what you heard. So also, we will discuss the first lecture at the end, so that we can combine these and are not interrupted. And interestingly, a lot of persons in the audience are nephrologists, so I think, yeah, this fits, and we will see how this works and how the discussion went. So then, Leo, you can start, I think.
Thank you, Dr. Weinmann-Menke, for the invitation, and welcome everyone. It's 8 a.m. here in Boston. It's a beautiful day, and I'm glad to be joining here through Zoom. And I have the role of talking about complement in transplantation. And this is such an exciting area, because I think there's a lot of potentials. But I decided to divide my talk in 2 major subjects, just because we have 25 minutes to go over those. And the objectives are to see what is the role of complement in antibody-mediated rejection, and what's the role of complement in some of the complement-mediated kidney diseases that can recur after transplantation, and how do we approach patients in terms of evaluation and management of both of these conditions. We'll start with the antibody-mediated rejection. And I have a very kind of simple way of understanding the immune system. I think about the immune system as having two major components: a component of the immune system that's responsible for the surveillance, to identify any potential danger that's happening in our body and to send signals. And then the second part of the immune system, or the compartment of the immune system, is what I call the SWAT team. So this is the more specialized part of the immune system that's able to recognize a specific threat, generate an appropriate response, and exterminate it. Much more specific, much more directed versus our surveillance here on the left. And the correlates of that is our innate immune system and our adaptive immune system. And if you look inside the innate immune system, the complement pathway is one of the components or members of the innate immune response. So, and we're going to be focused primarily on how this component of the innate immune response interacts with some of the adaptive immune response components, such as antibody-mediated rejection. And if we think about, the pathogenesis of antibody-mediated rejection, one of the key aspects of it is that there's a persistent immune response against a foreign antigen, most commonly HLA in transplantation. And this leads to, an interaction between T follicular helper cells with B cells. They mature, differentiate, develop high affinity antibodies, and ultimately become plasma cells, which are almost like this industry of antibody producing cells. They produce close to 10,000 antibodies a second. So they can become, major threats. And what's interesting about, when you're making correlations between cellular rejection and antibody-mediated rejection, in cellular rejection, we have these immune cells invading the kidney and causing local damage. When we're talking about antibody-mediated rejection, I see the correlate of it as these B cells and plasma cells that are located elsewhere, maybe in the secondary lymphoid organs, maybe on the bone marrow. And they basically throwing out these missiles, these guided missiles, which are the antibodies. And these missiles go into the circulation until they find their target. And if you think about the target, the primary target that our antibodies recognize in the setting of antibody-mediated rejection in kidney transplantation and other transplants is the HLA antigen. So the HLA antigen is the most polymorphic antigen that we have. And once these antibodies recognize the HLA antigen on the target tissue, primarily endothelium, is the first layer where they get in touch, they activate some effector mechanisms. And this is where complement pathway comes in, because complement is one of the ways in which antibodies can exert the effector function. There's also a direct endothelial activation that can happen with antibodies, but the second most common form of antibodies causing injury is through what we call antibody-mediated cytotoxicity. That's via Fc receptor PET present also in innate immune cells. So the innate immune response, even though it's the signal response that we discussed, has also a potential role of augmenting the effector function of our adaptive immune response. And in this case, complement in particular leads to the activation and causing injury. And if we step back and just have a 10,000 view of what's the complement cascade, it's a proteolytic cascade of reactions present mostly in the plasma. And ultimately, they have three major functions. They can induce cytotoxicity by causing direct injury to the tissue that express some of the end complement pathways. They can cause chemotaxis, so attract more immune cells into the system, and they can also enhance the antigen-presenting cell response. So all these three components can play a major role in causing injury to the allograft in the case of rejection. This is a very simplified view of the complement activation cascade. So you have these three major pathways: classic, the menin, binding lectin, and the alternative. I think what's interesting here is, in particular for the nephrologist, when we talk about antibody-mediated rejection, unfortunately, we cannot detect immune complexes being deposited in the kidney targeting the HLA antigen. So a lot of times, we actually base some of the presence of antibody on both the presence on the circulation of this antibody, but also of C4D present a deposit on the endothelium. We'll talk a little bit about it. But as the cascade kind of rose, as the C1q here, when it's antibody mediated primarily, leads to the C3 convertase, C5 convertase, some of these anaphylactic toxins or chemotaxis agents that attract more immune cells. And ultimately, what we also know is that the membrane attack complex is this final pathway of complement that can cause injury in the target tissue, and primarily endothelium in the case of antibody-mediated rejection. So one of the main things that I want you to get out of this is that we use C4D staining as an evidence that antibodies causing injury to the allograft. And this is because when there's complement activation, the C4D is kind of a split product of this complement cascade and get covalently bound to the endothelium. And it becomes stable for a few weeks. And this is a immune fluorescence staining showing this peritubular capillaries that are staining for C4D. So instead of, unfortunately, since we're not able to see the antibody kind of binding to endothelium, this is an evidence that this antibody are actually causing complement activation. And then you see this diffuse staining. The acute antibody-mediated rejection tends to have, in more than 50% of cases, positive C4D staining. This is different from what we see in the chronic antibody-mediated rejection, those that happen maybe slower and many years after transplantation, that actually the majority of the cases do not have a strong complement activation. But this is just important for us to kind of understand how complement kind of plays a role. And then if we dive into, the histology on the left side, these are some of the characteristic findings of antibody-mediated rejection in the case of kidney transplantation. So you see those peritubular capillaries that get distended, have immune cells invading, and you also see similarly glomerulitis, so inflammation on the capillaries of the glomeruli. And the C4D deposition is an evidence that there's some effector function happening with the antibody being targeting the HLA, and as well as the presence of donor-specific antibodies. So here I have a question then for you guys. So is complement inhibition effective in the prevention of chronic antibody-mediated rejection? And I'll get the help from Eugenie to actually put the poll up so that it's just a simple yes or no answer based on what I just presented so far. And we'll give you 15 seconds, and I think we can then close the poll. All right, so we got almost a split, 50-50. So let's dive a little bit into this, okay? And I would say that complement inhibition, just to put it out there, it's not effective in preventing chronic antibody-mediated injury in the allograft. So let's think about a little bit about what's happening here. So when we talk about antibody-mediated rejection, so there is the sequence of events that occurs. As I showed you, that's this important B cell maturation and progression into those plasma cells, the industry that produces with a lot of alloantibodies, and then ultimately these antibodies would go into the circulation, cause injuries to the allograft. So there are two problems about just targeting complement inhibition in the case of antibody-mediated rejection. I think one, you are not targeting what's actually leading to the antibody production. So it is a little bit like, you're trying to, end a fire, but, you're still getting, bombs or, missiles landing on your land. So to make this, quite simple is that you're going to be able to potentially get that fire down, but there will be some chronicity that would happen because, if the missiles continue kind of landing on your land, there will be collateral damage. And this is one of the problems about, targeting the complement inhibition is that you're targeting just part of it. You're not completely kind of shutting down the system. The second is that antibodies can cause injury also independent of complement activation. So we do know that Fc-mediated cytotoxicity is also a way in which antibodies can cause injury. So overall, I would say that the complement inhibition can contribute to regulate some of that injury, but alone it's not capable of preventing the chronic antibody-mediated rejection. So among all the complement inhibitors, the one that has been tested more broadly has been eculizumab. All of you know that eculizumab kind of acts down on the pathway of the complement activation on C5 by kind of blocking the formation of the membrane attack complex. It still does not prevent some of the other effects, including, the C3a release that can cause inflammation and attract other immune cells. And this was one of the first studies, I still remember reading this paper about 10 years ago, in which they use eculizumab and measure what is the rate of antibody-mediated rejection in highly sensitized patients that were undergoing transplantation. So this was at the time where we used to do a lot of desensitization. So patients were not compatible. We would desensitize them and get them through transplant if they have a living donor. And looking at the short-term outcomes, and here we're looking at 3 months, the rate of antibody-mediated rejection in the eculizumab group was 7.7%, while the one who just got standard of care was 41%. So this was, I think one of the major papers that told us that, maybe complement inhibition is the key, the holy grail to try to control this antibody-mediated rejection. And also in the short term, there was no significant transplant glomerulopathy present compared to the control group that already have close to 36% of cases with transplant glomerulopathy. So we got a lot of excitement on this in the transplant world. However, there are other trials that came after. And some of these trials were then kind of randomized, so they were a little bit better. And this was one that conducted 102 patients that were randomized to either standard of care and eculizumab post-transplantation. And they look at a number of different things. And on this case, the acute antibody-mediated rejection rate was 11% on the standard of care, 17% on the eculizumab. The caveat to a lot of these trials is that, there's a heterogeneous group that sometimes get included in these desensitization kind of protocols. So this is, what may explain some of the differences. But, there was a slight reduction in antibody-mediated rejection. However, if we in looking at graft survival, it does seem that eculizumab could have a potential benefit compared to the standard of care. Though the difference on this specific trial that was randomized was not as significant. But let me show you one additional data outside of the kidney world that had also got a lot of attention from the transplant population. And this is on heart transplant recipients. So we know that, unfortunately with heart transplants, they can only get deceased donors. And a lot of them are sensitized. So it's hard to get them prepped with the desensitization prior to transplant. So what this case was done was comparing just trying to transplant a patient that had a DSA but a negative CDC crossmatch, and either use pheresis and IVIG post-transplant to get them through, or use only eculizumab. And here's the dosing of eculizumab. And the rest of the protocol was kind of similar across. And what they were able to show is that at 1 year, they could get a very good survival just with eculizumab, and very similar to what they would get with plasmapheresis in IVIG. And more importantly, there was a lower rate of antibody-mediated rejection, biopsy proven, in the cases of eculizumab compared to those that had gotten plasmapheresis and IVIG. So this is the paper that I want you guys to remember. That it was a follow-up of that initial paper that showed a major results in the reduction of antibody-mediated rejection, but this is a longer-term follow-up. And what this shows is that when you look down the line, so when you're looking a couple of years down the line into the groups that either got eculizumab or control, and they were cross-match positive patients. So these are kind of high-risk patients that underwent transplantation. And we look specifically at some of the chronicity, some of these endothelial injuries that goes into the CG score here. We can see that, there's actually a very high percentage of these patients that do develop some chronicity. So what this told us is that complement inhibition can help kind of control that acute antibody-mediated rejection that happens. However, if you don't target other parts of the pathways that are important for antibody-mediated rejection, you may steal some chronicity and injury to the allograft. So what I want you to get out of this part of my talk on complement inhibition and antibody-mediated rejection, first of all, to understand that alloantibody can cause injuries through two major mechanisms: complement activation as well as FC-mediated cytotoxicity. Complement inhibition with eculizumab can help reduce acute antibody-mediated rejection and can even salvage some kidneys that develop a very acute, severe hyperacute rejection post-transplant by trying to control some of the effector mechanisms of antibody. However, it cannot alone prevent chronic injury. And what are some of the caveats to that? So a lot of the trials that have been done has been mostly using eculizumab. We know there are other forms of complement inhibition, and there has been some smaller trials that have some challenges to recruit that are targeting proximal in the complement cascade. And so the benefit and the comparison between that and later cascade blocking, such as eculizumab, and their benefit in antibody-mediated rejection still remains to be seen. But most importantly, I think what we get out of this is that we have to think a lot like the oncologists treat cancer. So we have to think about targeting antibody-mediated rejection at different levels, similar to what we do, when we use immunosuppressive drugs just to prevent rejection. So I think we need to, not only block the complement pathway, but we have to be very aggressive in trying to suppress antibody production, shutting off B cells, because this is the only way to complementary trying to inhibit the antibody-mediated process and prevent some of the chronic injuries that we're seeing. And hopefully we're going to be seeing more of these trials that have this multi-target approach in antibody-mediated rejection. So from antibody-mediated rejection, we're going to kind of shift gears and go into the complement-mediated kidney diseases. So this is a broad group of kidney diseases that involve primarily an abnormal complement activation. And what is the underlying reason for that? Some are genetic mutations or gain of functions in some of the complement members. Others are, inhibitions that prevent the regulation of complement. And there's also the possibility of the development of autoantibodies that ended up affecting some of the enzymes that are important in the complement cascade. And in addition to that, we do know that some monoclonal gammopathies can also trigger this abnormal activation. And then you have this spectrum of diseases that are very heterogeneous in terms of presentation and so forth, but they have that common ground that all of them have abnormal complement activation as the background. And that is the atypical HUS, the C3 glomerulonephritis, and the dense deposited diseases. So when we think about recurrence of glomerular disease, I like to think about, what are the diseases that can recur very quickly, or which ones that can recur within a year or two, and which ones do recur kind of later post-transplant. This is important as we think about, okay, how aggressive do we need to monitor our patients and what should we be looking for? And this is a simple table that we have created, thinking about some of the diseases that can recur very quickly: systemic FSGS, atypical HUS, monoclonal gammopathy-related kidney diseases, some that may take a little bit of time to cause the kidney transplant to suffer the injuries, such as membranous nephropathy and some of the C3 glomerulopathies. And then we have others, such as IgA and membranous and lupus nephritis, that may take years to cause significant injury, because most of our patients are going to be on some sort of immune suppression that also affects their pathogenesis. So this is kind of an easy way of kind of thinking about this at the timeline post-transplant. And then if we dive into the specific diseases that we're discussing here, there's a lot of heterogeneity in terms of the risk of recurrence. So just to give you an example, so atypical HUS, you can have a risk of recurrence to go from 20 to 100%. So that is based on, what's the pathogenesis behind? Is it what specific genetic mutation may be involved on that? And of course, because of this broad kind of range in risk of recurrence, you also have a broad range in terms of the risk of graft loss, going from 5 to 40%. And with the use, and I'll show you some of the data, with complement inhibition as prophylaxis, we have seen a significant reduction in the risk of graft loss. If you compare the C3 glomerulopathies, dense deposit have a much slightly higher rate of risk of recurrence compared to C3 glomerulonephritis, but both are, close to half to about 2/3 of patients do develop a recurrence. And then if you have a monoclonal gammopathy, your recurrence can be close to 50%. And specifically the ones that kind of trigger complement activation. So this kind of gives you an idea of, how broad this range is and how important it is to try to understand a little bit more about the pathogenesis of these diseases. So when we think about transplant workup for patients that are coming to our eval clinic and they do have a history of a complement-mediated glomerular diseases, we do attempt to perform certain things. So I think that genetic testing, it's something that if it's available to you, we should be able to perform, and it may allow us to try to estimate some of the risks of recurrence. The second is to look for autoantibodies, such as those against C3 or the C3 or C5 nephritic factor, because that also can go into the equation as we're trying to risk stratify the risk of recurrence. There's some of the complement functional assays, such as measuring levels of C3, C4, CH50, as well as some of the complement regulators, as well as MCP, that can tell us a little bit more about, what components of the pathway may be affected. And finally, all of our patients with complement-mediated glomerular diseases should get an SPEP as well as serum free light chains to exclude the possibility that some of these complement-mediated diseases may be driven by a monoclonal gammopathy, because then we know how to specifically kind of treat that, and that may be important prior to transplantation to reduce their risk of recurrence. So in terms of atypical HUS, this is the best paper that have come out from the French transplant groups, and they attempted to do a more individualized approach in the use of eculizumab post-transplantation. We do know that complement inhibition is a very expensive therapy, so we want to try to use it in the most effective ways, or at least for the patients that will benefit the most. And what they did here is that they risk stratify patients according to some of the characteristics that I was telling you about: genetic mutations, presence of autoantibodies, and so forth. And they divided in 3 groups. And we go into details about the 3 groups in a second. But what I can tell you on the left graph here is that the risk of recurrence, the recurrence-free survival, is very different across those 3 groups. So the low-risk group, you see that the risk of recurrence is very low. The moderate risk is here, and the high risk is this curve here on the bottom. So clearly, there could be a separation based on some of these workup in order to us to risk stratify that risk. And on the right side, what I'm showing you is that if you apply a eculizumab prophylactic strategy in gray here, you can significantly prevent the risk of recurrence in those moderate to high risk patients compared to those that have not received eculizumab. So this kind of tells us that, that prior workup is really kind of important, and it may guide us into that. So what is the criteria that attempts to separate all these categories between high risk, moderate risk, and low risk? So the criteria involves a few things. So the presence of a prior recurrence of atypical HUS will fall into the high risk. The presence of specific pathogenic mutations on the atypical HUS, for example, when I gave a function of C3 or a loss of function mutation of some of the regulators. So these are cases that you definitely want to recommend eculizumab. On the moderate risk category, sometimes they do not have a genetic mutation, but they may have, low titers of an anti-FH antibody, or they may have some variants of unknown significance that may require further testing. And if that is not available, you may fit them into these moderate risk category. On this case, you can either apply some prophylactic eculizumab or plasma exchange, or do more active monitoring. And then in the low risk, those with isolated MCP mutation, or those that maybe had a positive autoantibody before, but now it's negative, those you can potentially just monitor the patients post-transplant without any prophylactic therapy. So what is the best strategy? Do we do prophylactically, or do we do early treatment? And I want to give you kind of a flavor that there are some centers that actually, think that early treatment is a better strategy, just because, it can be more cost effective, and because, it would allow us then to use some of these resources on a more selective basis. So there's a Dutch group that have published a few cases of this, and one of them was on 17 living donor recipients, which had atypical HUS undergoing transplantation. They did only the active monitoring post-transplantation, and they aimed for a lower FK trough levels in case that was contributing to some of the endothelial injury. And they had only 1 case of recurrence of this cohort. Again, it's a small cohort, and this was successfully treated with eculizumab. So it is possible in some cases to actually do this more, expectant kind of management. I think, on the high risk group category, if you have some of these tools to do some of this additional workup, so I think these are the patients where the high yield of using some complement inhibition would be better. And what type of strategy can you use in terms of complement inhibition? So majority of the trials use a strategy as I'm depicting here. So you give 1,200 milligrams of eculizumab within a few hours of surgery. You then give an extra dose at around post-op day 1. And then you do about a weekly dose for a month, and then you switch into every 2 weeks of a dose of 1,200 milligrams following that. The biggest caveat with a lot of these complement inhibition therapies is that how long do you keep that for, and can you try to do some withdrawal of that? And I think that we don't have solid data to support. Some centers may use that same risk stratification to decide, in the high risk group, they would tend to continue this for a longer term. On the low moderate group, they may try to wean after a few months. We didn't talk to some of the issues about the ischemia reperfusion injury, because that's another separate category of potential ways in which complement can activate it and lead to this cascade that, if there's any problem in regulating it, may lead to injury. So, patients that have a longer ischemic time, therefore may have a tendency to activate more complement. And in these patients, potentially using complement inhibition may allow to control some of that. So from atypical HUS, I'll have 2 slides just on C3 glomerulopathy. So as we know, this is based on C3 deposition in the glomerulus in the absence of a major immunoglobulin deposition. The recurrence rate goes from 67 to 84%, with a median time of recurrence around 14 to 28 months. So it takes a little bit longer for us to see actually injury. And important in all these cases where there has been C3 deposition identified on the biopsy on the native kidney is to exclude the presence of a monoclonal plasma cell dyscrasia by SPEP and serum free light chains. So, and that brings me to another question that I want to put it out here. And so this was an actual patient that I had. So it's a 25-year-old male with end-stage kidney disease due to C3 glomerulonephritis. We reviewed the native kidney, profuse C3 deposits, a very active glomerulitis. We did some genetic testing. There was no pathogenic complement mutation identified, but he was found to have a low-level C3 nephritic factor. The soluble MEC, so that's kind of the end pathway of the complement activation, was elevated around 2.8 milligrams per liter. And the question here is, if this patient undergo transplantation, should you recommend eculizumab prophylactic treatment at the time of transplant? And it's a yes or no. And of course, these are cases where there's no wrong answer, and it really kind of depends where your risk is and some of that risk assessment. But I'll tell you what we did and go from there. I'll give you 10 seconds. Great. So 69% of you decided that this patient should get eculizumab, and 31% decided that this patient should not get. So let me tell you what we did. And again, there's no right or wrong answer on this case. We did not give eculizumab on this patient. And let me tell you what happened with him. So he's now 9 years post-transplant. We did 3 protocol biopsies to ensure that there was no significant kind of injury. What is interesting is that we could detect some C3 deposition in the glomeruli, but there was no ongoing inflammation and no ongoing scarring. So it seems that, with the immune suppression that he was getting for transplant, that was enough to keep, his complement activation kind of pathway, or at least some of the activators of that in quiescent. And his creatinine is like 1.8 now, 9 years post-transplantation. So, if this was 9 years ago, again, complement inhibition was not something that was so broadly available. We really had to select our patients to use it, and there was not a lot of evidence that we could base some of the argument between the insurance companies to do. So would that be wrong to be using complement inhibition? No, I don't think so. But again, this is what we did on this specific case, and we had some good outcomes. Which category would he be? High risk, moderate risk, or low risk? I think he would be more on the moderate to low risk, just because he didn't have a genetic mutation and he had only a low level of that C3 nephritic factor. So this is a little bit how, retrospectively, how you would position them on that category. So I think both options would be reasonable. So there's not a lot of data in terms of, the monitoring of these patients after they undergo transplantation, and the association between serum complement abnormalities and the risk of recurrence. But we do encourage, of course, all these patients to get enrolled in research studies so that, genetic testing can be done. Some of the functional assays can be done prior to transplantation, and that we monitor some of these complement assays, in particular the functional assays post-transplantation, in addition to, of course, monitoring the creatinine, monitoring for proteinuria, and some of the other things that we do to detect kidney injury. And I think in terms of data that we have, everything is based on case series, and we know that there's always publication bias when we're talking about that. And I think we have to just try to individualize our decision as much as possible based on the available data and potentially use that. And of course, if it's a patient that had a very aggressive disease upon presentation that progressed to end-stage kidney disease very quickly, you may argue that independently of what you find, or even if you don't find genetic mutation, you may decide to use some complement inhibition. And these are some of the things that, of course, we have to individualize the care. And I think it's so important to do. So I'll put just a final plug into the TANGO consortium. So this was a consortium created by myself and Paolo Cravetti from Mount Sinai, and it's specifically focused on the study of recurrence of glomerular disease post-transplant. And the impetus to create something like this is really because of the heterogeneity of glomerular disease recurrence post-transplant and how difficult it is to study on single centers what's happening. So we have now close to more than 500 patients that have been enrolled in this study. And there are close to 36 transplant centers worldwide that are part of the TANGO consortium. And it has led to important publications. This was one on FSGS recurrence. So one of the largest study in adults looking at the rate of FSGS recurrence, some of the risk factors or association factors that have been identified, and also what are the therapies that centers are using and their success rate in developing recurrence. And progressively, we've been kind of tackling different diseases that recur. We did FSGS. We did a paper on IgA nephropathy. We have an ongoing paper being finalized now on membranous. And we are starting, actually, in a couple of weeks, the complement-mediated GN study, which also incorporates, close to 26 different transplant centers in the world. And we'll be happy to include. So if you have a large transplant center that has a large volume, we'd be happy to include you in the TANGO consortium. And this is one of those kind of international projects that we feel that we can make an impact by kind of learning from each other and really kind of diving into some of these small numbers and trying to build stronger data to drive our decision. Because unfortunately, waiting for a randomized trial, waiting for other things to happen may take years, and our patients deserve better. This is some of the contact, the tangoxstudy.com, our website, or email, and feel free to email me as well. And it was my pleasure to spend the past 30 minutes with you, and hopefully we'll see each other in person soon. Thank you.
Great. So thank you very much for this really interesting and great overarching talk about like transplantation and complement-mediated disease after transplantation. I think we have there a lot to discuss. So, but we will move forward to the next talk that we have then some minutes at the end to see what we can discuss there. So actually, I will introduce now Professor Sidney Tang. He can actually not join in person to give his talk, so he did this in advance. So Professor Sidney Tang is currently a chair professor of renal medicine and U professor in the nephrology at the University of Hong Kong. And his research topic, clinical as also in the basic science, is in the field of nephrology. And actually, he focuses on the dissection of important intercellular pathways, which especially in the area of albumin, glucose, glycolated proteins, and its toxicity in kidney disease. Yeah, so I think we will go forward with the talk. And yeah, thank you very much that he also did this in advance, and we cannot see him now, but we will see the talk now.
Hello, everyone. I would like to thank the ISN and KDIGO for inviting me to give this talk. This is actually the fourth and last of an ISN-KDIGO Complement in Glomerulonephritis webinar series. and my task today is to talk about complement in diabetic kidney disease. These are my disclosures. I'm not sure whether you have attended the previous 3 webinars, but for those of you who are not familiar with complement-mediated kidney diseases, I would like to introduce you to this complement-mediated kidney diseases toolkit recently launched by the ISN. In this toolkit, you will find very useful information about complement-mediated kidney disease and indeed including the complement cascade. And I would like to take this opportunity to thank the contributors of this very interesting toolkit, including Vladimir Tesser, Liz Lightstone, Gary Chan, Namrata Parikh, and Nicholas McGerald-Thomas. So if you have not attended the previous webinars, or if you're not familiar with the complement cascade, this is a very good opportunity for you to revise what this cascade, what this complicated cascade is about. So we know that the complement system is part of the innate immune system. This is a system which contains 3 pathways: the classical, lectin, and the alternative pathway. The classical pathway is activated by binding of the C1 complex, C1q, R, and S to the antibody portion of the antigen antibody immune complex, the binding of which would cleave C4 and C2, leading to conversion to the formation of the C3 convertase. In the lectin pathway, this pathway is activated through the recognition of carbohydrates by mannose binding lectin, or the recognition of N-acetylglucosamine by phycolines. Upon binding, MBL-associated serine proteases will be activated and cleave C4 and C2. Now, the alternative pathway is quite interesting. The alternative pathway can be viewed as the policemen patrolling our streets. The policemen patrolling our streets are usually not very prominent. They are at the background, working at the background. If nothing happens, they would just be patrolling the streets, right? And if anything happens, they will be on site and ready to react to whatever emergencies that come up on the streets. So the alternative pathway is actually a system that involves spontaneous hydrolysis of C3, leading to the formation of complement components ready to attack any pathogens or danger signals. And of course, this would also involve a number of cofactors listed here. So the 3 pathways would actually converge to result in the cleavage of C3, which would then lead to a terminal pathway activation, which would ultimately cause the formation of the membrane attack complex, MAC, or the terminal attack complex. So this complex would insert into cell membrane and cause cell lysis. A number of diseases actually feature complement heavily, and they are shown here. And I believe many of these diseases have been covered in the previous webinar series. You don't actually see diabetic kidney disease here, but I think DKD involvement of complement is actually coming along. So my task is today, I will be talking to you about the role of complement in diabetic kidney disease. But before that, I would like to also show you some evidence why complement is important in the whole host of different conditions as listed here. This is partly, of course, due to the fact that the kidney may be able to synthesize complement. Traditionally, complement is actually thought to be synthesized mainly by the liver. But we have some data to show that the kidney actually may produce complement. And to prove this, we have performed some study using the concept of allotype conversion. And in order to prove the in vivo contribution of an organ-specific protein to a circulating pool, 3 criteria would need to be met. Number 1, that the protein must exist in 2 or more allotypic forms. Number 2, the organ must be transplantable from a carrier of one allotype to a recipient of another allotype in order to achieve what we call the allotype mismatch. And then the 2 allotypes must, of course, be detectable and quantifiable. So using this basic concept, we looked at the effect of transplanting kidneys from donors with C3FF, the fast allotype, or the C3FS, allotype to a recipient who is homozygous for the S allotype. So after transplantation, we can actually measure the amount of C3F in the C3S only producer, and then we can actually infer the amount of complement C3F that is coming from the transplant kidney, and therefore we know how much complement is produced by the kidney, and this can be expressed as a percentage of C3F to total C3 in that recipient. So this is showing you that donor-derived C3 during graft rejection may actually occur. You would see that after kidney transplantation, during the acute episode of rejection, that actually the circulating pool of complement C3 coming from the transplant kidney amounted to some 10% of the total circulating pool, whereas during the quiescent state or the steady state, 3 to 13 months after transplantation, approximately 5% of the total circulating pool of C3 is actually coming from the transplant kidney. So the kidney is actually producing complement and not just the liver. And when we look at the cell types that are responsible for producing complement in the kidney, we found indeed that it is the kidney tubule cells. And here we used an in vitro model to stimulate tubule cells with serum proteins and found that the tubule cells actually would synthesize C3 protein. And if we look at different fractions of the protein that are responsible for stimulating tubular synthesis of complement, we found that it is actually the albumin and the transferrin components of serum protein. So this is the background of complement synthesis in the kidney, and I would like to hope that in the remaining time I can convince you to understand that complements are activated in diabetic kidney disease, and that some animal models of DKD would prove the involvement of complement components. And finally, we would want to understand how inhibition of complement may potentially protect against DKD. So I would just like to show you first some clinical data, mainly from human specimens, biopsies, blood, and urine. So this is a study from our group, Dr. Yu, showing on the left-hand side would be the human kidney biopsies, and you can see that patients with biopsy-proven DKD or DN, diabetic nephropathy, they had increased staining of C5a in the biopsy specimens, and they also have, well, not really increased, but they also show expression of C3a receptor in both control and also diabetic nephropathy subjects. So the IOD value shown here clearly show that C3a is overexpressed in patients with diabetic nephropathy. And indeed, the degree of C5a staining increases with the severity of diabetic nephropathy, as shown here on the right. This is another study looking at the urine complement proteins and the risk of kidney failure in patients with type 2 diabetes and biopsy-proven diabetic nephropathy. There are 26 subjects in this low decliner group and 28 subjects in the fast declining group. And you would see that this is the area under the ROC curve for the prediction of kidney failure. And you see that the amount of complement factor H and decay accelerating factor, they actually had a larger area under the curve than the clinical parameters of eGFR and proteinuria in predicting kidney failure. So here, this is also a plot of the abundance of urinary complement components, and you would see that the urinary concentration of C3, C9, and factor H correlated negatively with eGFR decline, whereas urinary C5, DAF, and CD59 correlated positively with eGFR decline. So these are some evidence that complement may be involved in DKD and its progression. This is another study looking at not just urine, but also plasma levels of complement proteins in a larger group of subjects, diabetic subjects with and without diabetic nephropathy. The demographic data is shown up here, but you can see from the levels of complement proteins in the plasma and also in the urine in these two tables below. And of note, you can see that complement C3a and C5a okay, are much higher in patients with nephropathy than patients without nephropathy in the serum. And the same is also true in the urine of patients with nephropathy being higher than patients without nephropathy. So these are all type 2 diabetic subjects. So mainly C3A and C5A, and possibly also the lectin pathway components. So here I would like to show you a more recent study looking at the activation of the alternative complement pathway in the glomeruli from patients with diabetic kidney disease. On the left here is a heat map of differentially expressed genes enriched in alternative complement pathway in the gloms from human kidney biopsies with diabetic kidney disease, and you can see complement factor B standing out. And indeed, the kidney biopsy also showed an increased expression of complement factor B in the gloms and more severely in the tubular interstitium in patients with DKD. Okay, let me now move on to talk about some of the animal models of DKD showing the involvement of complement and whether inhibition in these experimental diabetic models may actually protect against the progression of DKD. So this is coming back to our study again. So we looked at serum C5a and C5AR levels in diabetic DB. These are type 2 DB animals, type 2 diabetic animals, mice, versus their non-diabetic littermates. And you can clearly see an increased serum level of C5a, which is significant statistically, and also a trend towards an increased gene expression of C5a receptor in the DB animals versus their non-diabetic littermates. So when we applied a C5a inhibitor, the NOX-D21 shown here, this was a gift given to us, but I think now this is available commercially. You would see that the DB animals displaying severe glomerulosclerosis and also tubular interstitial damage would have a reduction in the severity of these lesions after the application of NOX-D21. And likewise, the C5a inhibitor also reduced tubular interstitial fibrosis in the kidney, and there is also reduced expression of fibronectin and collagen 1 in the kidney of these DB type 2 diabetic animals. And indeed, the NOX-D21 also inhibited TGF-1 beta-1 driven kidney fibrosis in these animals with reduced expression of fibronectin and also collagen 1, and indeed also of TGF beta-1 itself. So this is another study that further substantiated the role of C5a in diabetic kidney disease. And shown here on the left-hand side are some data showing that renin-angiotensin blockers actually did not influence complement levels in type 1 and type 2 diabetic models. So this is the type 1 Akita model, and you can see that in the kidney and liver and also in the urine that there was increased C5a expression. In the type 2 model, likewise, you also see increased expression of C5a receptor 1 in the kidney and the liver, and also increased urinary excretion of C5a. And shown at the bottom here, it's the time changes, and you can see early on at 4 to 8 weeks, there was increased in C5a receptor 1, and later on, there was also increase by 16 to 32 weeks, there was increased urinary C5a expression. So coming on to gene deletion of C5a receptor 1, whether it can protect the kidney from diabetic kidney injury. So here you can see that by the application of deletion of C5a1, C5a receptor 1 expression in these animals, that there was reduction in albuminuria, reduced oxidative stress, reduced infiltration by F480 positive macrophages, and also FOXP3 regulatory T cells, which is actually increased because the FOXP3 regulatory T cells are thought to be cells that are important in ameliorating inflammation in the diabetic kidney. So the more cells, the better. So here in the immunohistochemistry, you would see a reduction in F480 macrophages, but an increase in FOXP3 regulatory T cells in these animals. Now, PMX53 is an orally active C5a receptor inhibitor, and you can see that it actually offers some advantage in protecting the diabetic kidney, in reducing albuminuria, oxidative stress, plasma IL-18 concentration. The PAS staining also showed a reduction in histologic damage after using the PMX53, and other markers of fibrosis, including collagen 4 and also Pico series red staining, show reduction in kidney fibrosis, and also there was reduction in macrophage infiltration and an increase in the number of FOXP3 positive regulatory T cells. Now let me move on from C5a to C3a. Okay, so this is a recent study from an Italian group to show the glomerular activation of C3a in animals with type 2 diabetic nephropathy. The model that was used is the BTBR OBOB model, which is a severe form of type 2 diabetic model. And here you would see that there was increased C3 staining in the glomerular compartment, and a close-up of the gloms actually showed indeed that the podocytes are actually expressing C3a in the diabetic animals versus the control animals. And shown here on the right would be the staining showing that the expression of C3AR and also nestin here in green, and the merging actually shown in yellow. Red arrowheads indicate that the cells that were actually expressing C3AR are actually the podocytes. So the podocytes are actually overexpressing C3A in the diabetic BTBR OBOB animals versus the control. So what about the application of an antagonist of C3A receptor? So here you see that these animals, they had increased albuminuria, but shown in the dark dots here, the application of a C3A receptor antagonist in these type 2 diabetic animals would markedly suppress albuminuria. And you can also see here that there was actually an increase in the number of a restoration of the podocyte number in the diabetic animals if C3A receptor is blocked. And the plot here on the right show that there was a restoration of podocyte number, podocyte density, and also a reduction in glomerular volume in the animals that received the C3AR blocker. So functionally, the C3AR antagonist would also limit podocyte dysfunction in these animals. So shown here, you would see that these animals had reduction of nephrin and alpha-actinin 4. These are the podocyte slit diaphragm protein markers, and they were actually restored in the animals that received the C3AR antagonist. Now, so the function I was talking about, the first one is a mitochondrial function. Here you can see that the diabetic animals had a morphologic abnormality of the mitochondria, and they were partially restored with the application of the C3AR antagonist. And in cultured podocytes, indeed, using this mitotracker, you can see that C3A expression, okay, the cells with altered mitochondrial pattern was actually increased when C3A was added to stimulate these cells, okay. And here you would see that the mitochondrial network is reduced if C3A is applied, and so is the individual mitochondrial number, the counts per cell, and also the mitochondrial area. So C3A actually causes a mitochondrial dysfunction by affecting its morphology, and also by reducing its number, and also its function. So here shown on the right would be some data on oxidative stress, and you can see that SOD2 is restored, whereas nitrotyrosine and oxidative stress marker is reduced in the animals that receive the C3AR antagonist. So this is the graphical abstract of this paper summarizing the effect of treatment with a C3AR antagonist from 9 to 14 weeks of age in these BTBR OBOB severely diabetic animals with severe DKD. So this would lead to reduction in albuminuria, reduction in phenotypic changes of the podocyte by restoring some of the sleep diaphragm proteins and preventing podocyte loss, and also restoring some of the mitochondrial function and reducing oxidative stress. Okay, let me use the remaining time to talk about complement factor B in the alternative pathway. So this is a more recently published study, I think it's coming from Guangzhou, China, in which the animal model used was an STZ-induced type 1 diabetic models. And these animals then had complement factor B silenced versus control, and they were sacrificed at week 24. And you can see that these animals displayed rather severe albuminuria, but in animals in which factor B was silenced, you would see a reduction in albuminuria close to control. And also the podocyte, the complement factor B expressing podocytes is also increased in the diabetic animals, but in the knockout animals, this was markedly reduced. So shown here, down here, would be some of the sleep diaphragm proteins, and once again, you see that the animals in which there was silencing of complement factor B would show a restoration of nephrin and also Wnt tumor factor, Wnt tumor 1 WT1, as opposed to control. And the same is also true for mitochondrial morphology. And here you can see an abnormality of mitochondrial morphology, which is partially restored in animals in which complement factor B was silenced. So this is just to show you some of the theory effects of inhibiting complement factor B. So there would be a reduction in complement C3d expressing podocytes, reduction in C5b29 positive podocytes, a reduction in C5aR positive podocytes. In addition, the kidney weight, glomerular area are also reduced, and conversely, the number of WT1 positive podocytes are increased in mice in which complement factor B was silenced. So coming to the summary of my talk, I hope I have convinced you that in human kidney biopsy that there was a heavy involvement of the different complement components, and this is also the case in the urine and also plasma in human clinical specimens. And moving on to the various animal models I have actually described, including the type 1 model, which is the Akita model, and also the STZ-induced model, and the type 2 model, which is the DBDB model, and also the BTBR-OB model. I hope you will be convinced that complement is actually activated. And actually, this is a summary to summarize how during diabetes, complement can affect the onset and also the progression of diabetic kidney disease. And in short, in response to the diabetic stimuli of hyperglycemia or advanced glycation end products or dysproteinemia or dyslipidemia, and so on, or even hypoxia during DKD, these cells would actually cause an increase or an activation of mannose binding lectin, which will be activated in association with MBL-associated serum proteases to cleave C2 and C4. There is also ample data that C3a and also C5a are involved during the hyperglycemia and also diabetic condition, and all these would converge to give rise to the activation of the classical lectin and also the alternative pathway, leading to the activation of the terminal complement pathway to lead to the formation of the membrane attack complex, which would then cause a lot of cell injury. And because the kidney is able to synthesize complement, this may actually be amplified in the kidney, in particular in the tubular epithelial cells. And we know from epidemiologic studies that the kidney tubular epithelial cells are the very cell type that determine ultimate kidney prognosis. and therefore the damage to the kidney tubular epithelial cells could explain the clinically observed tubulointerstitial changes, namely inflammation, interstitial inflammation, and also fibrosis in patients with progressive kidney disease. So with that, I would like to thank you for your attention.
Yeah, so thank you very much for this so interesting talk. And yeah, I think the complement is pretty important in a lot of disease, and now we only have to find the way which is the right target actually of the complement system at which point, I think. I think if you have any questions, you can write them in the Q&A, and we have already some questions and some got already answered, I think. But I think I have actually one question after it's to Dr. Riella, after kidney transplantation, and when you have like the time frame of recurrence, do you think that we maybe should start a prophylactic treatment in some disease? When you look at your study, the Tango study, and you see the FSGS and maybe the complement C3C glomerulonephritis, I think it's pretty unclear when should we start.
No, that's a great question. I think, as you said, where do we target the complement cascades, how much we give, and the timing, right? And also the duration. So I think these are kind of 4 different parameters that complicates, I think, how we interpret even the data that's out there. So I feel that it all depends also on the resources available, and I'm cognizant that we have this international webinar that in some other countries they may not have the same resources that some of the maybe developed countries may have. So I want to be aware of that. I think we tend in the US we tend to do more than less. So I think if it's available, I think most of the transplant centers would favor in some of these conditions that there's a high risk of recurrence early post-transplant to implement that early on. But I feel that based on the data that we have for specific conditions like atypical HUS and like such, I think there's clear evidence that some of these prophylactic early on may be better and may prevent complications from happening and instead of you catching up later. But I think it's so heterogeneous, the population of all these different diseases, that it's hard to make a one size fits all. So I want to everyone to kind of be aware of it, and if there's possibility of centers to include patients in research studies to better understand, to perform genetic testing, to do other things that may not be available in the clinic, this would be something that I'll definitely kind of encourage everyone. So the more we learn about it, and we have to learn unfortunately as it goes, I think the more we're going to be able to kind of guide and do the appropriate decisions going forward. What's your experience? How have you used eculizumab or inhibition in transplant?
Yeah, actually, we use it, and it's all the time a discussion when we have a patient before transplantation. Do we try to stop it and see what happens, and then we start again when something happens? Actually, we did it a couple of times now, and in some it worked. We did not have to use eculizumab through transplantation, and everything was stable. And then we had other cases where we already recognized before transplantation, okay, so that's not working. So that's obviously now a life-spanning therapy. But I'm sometimes a little bit, I'm not sure if these patients, and they get like a triple immunosuppression and eculizumab, so then sometimes maybe we get more infections. Until now, I did not see this. I don't know, maybe you have, I think, a lot more patients than me, but did you see a lot of more infections in these patients?
I think that there's a risk, Julia, as you said. I think, the infection risk has to take into account a lot of factors, including the age of the patient, their prior infectious history as well. But the more we give, I think there's always this exponential risk of having that. So you may favor in the younger patients maybe being more aggressive, because we know that we want to try to extend the life of the kidney and prevent any injury. And maybe on the older patients, you may say, okay, let's be a little bit more, conservative and do a kind of a monitoring. So I think that strategy and thinking, individualizing to the patient is super important.
Yeah, and what I never actually do is that I stop eculizumab after transplantation, because there is actually a question: what is the duration of eculizumab after transplant? So then I think they're too dangerous that I get then a complication and then lost the transplant. So we try to test it before transplantation if it is possible without eculizumab, and otherwise we tell the patients they have to take it forever. Yeah.
Yes.
So,
this is one of the, I think with the longer acting complement inhibitors, that can help somewhat, start extending things more. But no one size fits all, unfortunately.
Yeah. Okay. Yeah, so I think we're actually on the end already of our nice webinar, and I think we had a lot of discussion and really interesting talks over like the whole area of transplantation, of diabetic kidney disease, and I think we will hear a lot more about the complement system and new targeted or not new therapeutic options in the future. I think there are a lot of clinical trials running at the moment, and I really think every patient who could be in a trial should be in a trial, that we get really good data so that we then can treat our patients perfectly, hopefully in a couple of years. So thank you very much to everybody, and have a nice day then.
Thank you, Julia.
Yeah, bye. Thank you.
Thank you.